We are live with Hillsdale Hospital, and today is Wednesday, February 21st. We're here to keep all of you, our patients, families, neighbors, and friends in the know and up to date on the latest health news in our community. I'm Rachel Lott, Chief Communications Officer, and I am joined by
JJ Hodshire, President, Chief Executive Officer. And last Wednesday, Rachel, we had our Facebook Live. Last Wednesday was Valentine's Day.
Oh, that's right.
How did Andy do for you?
Oh, great. We celebrated early. So my birthday is on the 11th.
That's right.
So we did like Saturday and Sunday celebrations.
So 25th birthday awesome. And
21.
Oh, was it 21?
Yeah, 21.
Oh, whoops, my bad.
Super young.
25. I was thinking about Ken. Yeah. 25.
Oh, right.
Okay. All right. That's my bad.
Yeah.
Exactly.
And unfortunately, I was sick on actual Valentine's Day. So.
Oh, well, see, it didn't work out.
Yeah.
Well, it's great to have our listeners here today, and it gives me great honor and privilege to introduce a good friend of mine and a tireless worker here at Hillsdale Hospital who is really in the background most days and just really plowing through, seeing lots of patients. You would be absolutely alarmed, and we're going to talk about that, the volume of patients that goes through this guy's practice and office. But it is an honor to have Ken Rubin here today with us. Ken, nurse practitioner out at our orthopedics office. And for those who you've been here once or twice on our program,
once,
yeah, and it was a long time ago.
A couple years.
You and I did not have gray hair back then, and so I would just like for the listeners just a little bit about you, overview where you come from, how long you've been with Hillsdale, and a little bit of what you do.
Sure.
Out there at orthopedics.
So briefly, I grew up in Livonia, Michigan, and I moved my senior year actually to Hillsdale. My mom was here. Finished my senior year here, left 4 days after graduation for the Army. And I was in the Army 4 years active and altogether almost 14 and a half years with reserves combined.
I didn't know that.
I did a tour during a Desert Storm, and I got to do some Egypt, Guatemala, El Salvador, a few different other trips. I started off in the medical field in the military as a surgical tech and first assist. Then I changed over to combat engineer after about 4 years, thinking that'd be a change, and it was. So I got shipped all over the place as a combat engineer. Finished as a staff sergeant, and I was on my way to Afghanistan doing mountain training up in Denver, Colorado. And they came to me and said, Staff Sergeant Rubin, we have too many staff sergeants. We're going to send you home.
Thank you.
And I was being extended at this point. So because of that, once I got sent home, I said, I'm done.
Yeah.
Because I wasn't going to go with another unit. I wanted to go with my own unit.
Right.
And I signed out. And then about 7.5 years after that date, I got my nurse practitioner degree, master's degree in ortho. And I've been doing orthopedics for 14 years now.
So Ken, did you start, so you always knew you wanted to be an ortho?
You know, I always knew I wanted to be medical. I didn't really know
what specialty
ortho until I started working as an RNFA. And then you work with all the specialties that way as a first assist RN. And I got to do all the different.
Oh, I didn't realize you were the RNFA. Okay.
I was. And I got to do everything from OB to general to ortho. And the first time I started working with ortho, and you get to use power tools and do cool things like that. I'm like, this is amazing. Yeah. And I found a love in it, found great mentors since that time. And I just keep learning as I go through to try to be the best.
Yeah. Now, over the years, though, that has changed for you because you used to be in the OR.
I was in the OR 27 years.
Yeah. That's transitioned for you.
It did. So because of an old Army injury, I had an injury, a 5-ton dump truck flipped over, hurt my neck and crushed my shoulder. I was having increasing problems and numbness in my hands. So I had to step away from surgery. I'm going to say 3.5, 4 years ago.
I'd say about 4 years ago, yeah.
And I'm allowed to do 1 or 2 cases a year now, occasionally for a couple hours. But other than that, I'm pretty much all clinical.
Yeah.
So I've done a lot more training and learning to make sure I was up to date with the clinical side as well as when I was in surgery.
Right.
And I feel I'm pretty well.
Yeah. So let's talk a little bit about that real quick because you've transitioned from the surgical side now to all primary.
Correct.
And so what does that day look like for you?
So I have a vast amount of patients. So I see everything from new to follow-ups. I see post-ops for all the surgeons. I see new injuries. I see ages everywhere from probably approximately 10 years old to 96 years old. It can be injuries. It can just be chronic pain. It can be different things that get referred over from all of our primaries or from other physicians. And I've opened up an osteoporosis clinic in our office now. I did that probably about 5 months ago because we found a significant need in the community of patients that were just treating their osteoporosis after fractures. and we're not necessarily treating their osteoporosis to try to prevent the fractures.
Yeah.
And that's a huge need. So I've started that up, and that's been started growing. We're starting to get more referrals for osteoporosis, hopefully before the fracture, but definitely after the fractures, the surgeons will write a little note stating what the bone was like during the case and say, hey, see Ken, and I'll try to work them up, one, to help prevent fractures for future, as well as to strengthen and heal their bones that they're having done now.
Yeah. Well, okay. So my first question that I'll throw out, because that was just the intro,
This is your first question?
As this is my first question
Somebody go roll the tape.
of the
Somebody
script,
count.
of the script is, all right, you hear the word orthopedics, or someone on the street does.
Sure.
Okay? What does it all mean?
So that's a
Honestly,
good question.
I mean, it does mean a lot.
It does. So I did write a little bit down. Just
Does
to
it mean
help guide
surgery?
me. Not necessarily at all.
All right. So
No.
talk to us about what it is.
So orthopedics is just the treatment of injuries, diagnosing, affecting bones, musculoskeletal, soft tissue injuries of people in general. So it doesn't necessarily mean bones specifically. It can be anything. It can be the joint, could be a soft tissue injury from an impact, and can just be chronic pain. But there's a lot of diagnoses that also can be congenital, and also can be through our chemical makeup. So we have to go through a lot of different things. You know, rheumatoid arthritis patients or psoriatic arthritis patients, and they have bad knee pain. And if we were to just treat the pain and not treat the underlying source, that's an issue too.
Yeah.
So there's a lot that it encompasses.
Do you ever get someone just comes in and says, I want surgery? You know, and you have to talk them off that ledge.
I do, especially if at one point throughout their transition before they got to me, someone said you need it. And that's always a little bit of a
So
thing.
it's already on their mind.
Their primary care, or someone may have said you need surgery.
Whomever.
So they come
Or
in
a
with
friend
their
or
mind.
family member
Their
who's
friend.
like,
I had
oh,
the same thing.
right.
And then not necessarily, may have or may not have.
Or
But
may
once they
to a
hear
different
it
severity.
and how much better they are based off their surgery, you're like, well, let's go
They
through
want
this.
to feel better, yeah.
But I feel like this is an important part. I think that when I first see a patient, I generally am able to kind of figure out what it is they need. And if that means they want to hear that they're going to be okay and reassurance, if they want to know that I'm going to figure out what their problem is, I figure out that somebody just wants to hear technical jargon sometimes. I can kind of feel that out in the first few minutes. And then I try to get them at ease, and then we can transcend to how to fix the problem.
But I mean, to your point though, it's not all surgical intervention.
Not at all.
We're talking about some of the work that you do is working with PT. Some of the work that you do is injections.
Absolutely.
Coming back. In some of the cases, once you say you have a relationship with our pain clinic,
Absolutely.
and you are saying out of my office up to the pain clinic.
And also diagnostically. So I have a patient with, let's just go with hip pain. And the x-ray doesn't show that severe pain. We want to kind of rule out labral tear or something else. By having the pain clinic do an intra-articular injection of the hip and then following back up with me in a couple of weeks, I can say, did this improve your pain?
Right.
And if someone says none, didn't help at all, I have to go towards back now,
Right.
say.
Treatment
or I have to go
modality.
somewhere
More
else.
investigation, yeah.
So my injection in my shoulders in office sometimes are the same one. Sometimes it's for treatment. Sometimes it's diagnostic. If the injection did nothing for your shoulder, the chance of it being a shoulder pain or
Right.
shoulder injury is slim.
Yeah.
So it's an interesting thing that we use all types of modalities: therapy, injection clinic, the pain clinic, all kinds of things.
Excellent. Excellent.
Labs, obviously.
Yeah. So what about when a patient has an injury? So say they think they broke their ankle and they come in. Are you going to be able to, if you do an x-ray that day, are you going to be able to see and do everything you need to do that day if they just broke their ankle last night?
I'm going to, of course, say 99% because there's always the one outliers, right? But in general, yes, I can treat the injury 99% of the time and know what the problem is right away. Now, sometimes depending on if their joints malaligned or there's other tissue damage, ligament damage, you may have to get an MRI, and then you may have to decide if they have to have a surgical procedure. But I can tell pretty much based off the x-ray if this is something we can treat in-house, outpatient, without any surgical intervention or MRI or testing.
Right.
Just by the x-ray or the exam. The exam's important. I'd say the exam's more important of touching the patient than all the x-rays and then tests in the world.
Right.
And that's what a lot of people get stuck on, is we're going to just do all these tests without ever seeing the patient.
Yeah. So Ken, you let's talk a little bit about some of the procedures that you do specifically, because you're migrating out of the OR into the practice, but you still are giving injections.
Absolutely.
And one of the things that we hear about is bone on bone pain.
Absolutely.
And could you talk a little bit about what is it doesn't always have to be surgery, right? With
Correct.
bone on bone. What are you doing as an intermediary between that?
So there's quite a few different options depending on the patient's needs. So some patients are pretty active and they have, bad, let's say, medial joint line narrowing and pain, and they don't want surgery, can't have surgery. They want to make it 2 more years before retirement. There's a lot of options. So usually I start off with corticosteroid injection that drops inflammation and pain. I like to see how that responds for them. Then
how long would that work if you're given a?
I mean, I hope for it to last at least 3 to 4 months.
Okay.
But generally, if it's a really acute flare, I'm trying to just drop the inflammation down and significantly, get them on some anti-inflammatories, and then the visco supplementation, which the gel shots is the nickname.
Yeah.
Those are every 6 months. There's no side effects from gel shots, whereas multiple cortisone injections in the same joint can cause arthritis to get worse. So you try to transition and use the steroid more for acute. Visco every 6 months, and I have them routinely. Not wait till pain. You actually come in every 6.
It's a schedule 6. And are you finding that
helps a lot? I can buy years on a lot of patients without the total.
And what's the difference between the two?
The gel shot actually creates a thicker lubricity and viscosity of the fluid joint.
Okay.
So I try to tell most patients, like, change the oil of your car. Put the cheapest oil in the world in your car, or a nice thick synthetic, and you're going to have less friction, you're gonna have less pain or issues.
Yeah.
And same thing with why do we do the change every 6 months, if you will. You don't wait till your car makes noise.
Right.
You do the change every 6
point.
before, so to prevent more wear and tear.
That's a good point.
So it's a great option for a lot of patients. Most insurances are covering it pretty well. We're having some kickback over the last couple of years. There's a new med out called Zilretta that I'm doing right now, and it's also a steroid, but it's more in like these synthetic bulbs, so it releases much slower, which is great for my patients that have blood sugar issues. So I'm not seeing the spike,
right?
And then it lasts longer sometimes than the shot does itself.
Interesting.
It exudes slower, so we're getting that now involved. And then bracing. So some patients do very well with like a medial offloader brace or lateral offloader brace, depending on where their knee joint is.
I mean, that's cumbersome,
and
right?
that opens it up, and they can actually get around. It depends on how much they want to move. So if they're just wanting to get around that works very well.
Not an active job and busy,
and they don't want surgery for 1 year. Here's a brace. We can get you until a year, and then we sit them down to talk about total joints.
So one of the questions that I have is, all right, I notice I'm having pain in my knee, right? Do I have to go to my primary care first, or can I call your office directly? How does that work?
So
does the insurance companies pay for that if it comes to you first?
So there are some insurance companies that make you have a referral from primary, and some don't.
Okay.
So a lot of patients are going to have to find out a little bit on their own, or their primary may know. Now, my front desk is phenomenal. So they can actually tell a lot of my patients when they call or stop in, what do you have?
Okay.
And they kind of know right away. I could throw out Priority Health, I think, is one that always needs a primary. But if you're an established patient for anything else, though, with us, and now you're having shoulder pain, you can come see us. You don't need another referral.
You don't need for whatever.
So it's amazing.
So
it's
like
first time, yes. But if
even
I've
if it
seen
was
you
years
something
ago?
else, even if it was a different body part,
Is
you're
that
allowed to see it.
That's great.
So I do see patients once, and then I see them for multiple things and different things for years after that.
Now, Ken, are you seeing cases where individual wants the surgery, you recommend the surgery, but the insurance company doesn't allow for it? Do you see any of that?
I generally have not. And I think most of the time it's because I know the things we need to do prior
to get the authorization.
We do. And you do have to show that you've done certain things. And some of the patients, it could be you have to show a weight loss program. Some patients, it could be that you have to have done some therapy or injections or other modalities first. You have to have an MRI and or X-ray that does show what the reason you're wanting to do it.
So you kind of have an algorithm of Insurance X requires a weight loss program, injections first, and then progress to surgery.
And there's words, of course, that they make you show that the patient's having difficulty ambulating past 200 yards without rest, and they are using an assisted device of a cane or walker. All of these things feed. And it's more of a Medicare
kind
thing.
of what they're looking for in their criteria.
Right. And I certainly don't feed it just to get them to surgery either, but I do know what the requirements are to make sure the patients meet it.
Right.
So,
you know how to describe it and the way that the insurance company wants to hear it so that they have the information they need to do the authorization.
And then we have to look at a lot of the patients with uncontrolled blood sugar come in and they really do need a procedure done. And if their A1C is over a certain level, we can't even do an elective surgery.
Oh, wow.
So I would love to have that something we really I mean, everybody's trying to get it down anyway, I understand, but God forbid you have a surgical intervention. Let's say you do have a bad injury and you're not keeping your sugars well controlled. We're going to have to do this surgical procedure emergently. And now your healing is going to be a lot worse. Your increased infection rate. So that's another reason to keep your sugars down, not just for all the other
healthy
God
reasons,
forbid you get hurt.
Yeah.
Right.
And now you have an infected foot or ankle because you didn't keep your sugars under control prior. So,
So is that a scenario then where you refer them to Denise Levenger for diabetes education and support? I mean, depending on the patient,
depends
what
on
they
the
want
patient,
and
how
are
quick
willing to
the
do.
surgery needs to be done. I mean, there's, Dr. Bawachi also works with a lot of patients too that are already established with him, and he believes they're under control. And then we see them, they're like, well, I haven't seen my doc in a year.
Yeah.
And I stopped taking my meds, and I think I'm doing
there's
okay.
the problem.
Now your A1C is 10. So we work all together.
Right.
So I think the primary is
continuum that we have
endocrine.
available.
Absolutely.
Awesome. What are some of the things that makes our orthopedic practice stand out from other care options? Because we do some unique procedures that other places are not doing.
And that's one of the great things I believe about working the practice I work at is we have three physicians specifically that are phenomenal, and they each one has kind of a niche too. So I've worked in multiple places before, and it's, you have one doc maybe, and you don't have a whole lot of choices. Here we have three that have their own niche. So like Dr. Patel, he does upper extremity. He had an actual fellowship for an extra year over and above orthopedics. So he does, general surgery, of course, for general ortho, but shoulders, replacements, reverses, total shoulders, all kinds of amazing surgeries that aren't routinely done in smaller hospitals.
It's incredible, isn't it?
It's
what we can do here.
And absolutely, that's a big one. And then Dr. Hannah, as well as Dr. Carr, are doing anterior hips. And that is I shouldn't even say wave of the future now.
It is what's
the standard. It should be.
It is.
And patients are able to get moving the very next day, and they have a lot less pain, a lot less risk of dislocation. So that's a phenomenal option. And Dr. Carr does ACLs with grafts from the patients also, which is great for some of my younger patients. So I think that's the big key is we have three great physicians that each have a niche. Dr. Hannah does total knees and revisions and periprosthetic fractures. He's a trauma trained doctor. So I can have the right doctor on the right case with the right person pretty quickly in my own place.
Right. Ken, quick question, because I know our time's escaping here, but sports medicine, you have a lot of athletes. Absolutely. You have Hillsdale College, you have Jackson College in our area. You got students.
Absolutely.
What's your practice in relationship to sports medicine? What are you doing to work with that population?
So I definitely think we have a good key in there, especially with the high school and the college specifically. And they come to us for their injuries and basketball injuries and volleyball injuries and ankle injuries. And I'm able to get them back to sports as quickly as possible, safely.
Sure.
And also prevention. I think that's the part we keep forgetting all the time. Let's fix what caused the issue.
That's a good point.
And we try to make sure we prevent the next injury and get them stronger quads for risk of ACLs and things. So I think we do that a lot.
Yeah. Do you have a success story of someone that, not even a student, but I don't care what their age is, that someone that came to you and it was just, wow, we really did well for that patient?
So I have I'll try to be quick, but I always try to say about 22%. It's kind of a joke, is that I hope that at least 22% of my patients come out really excited and happy that they've seen, because we can have different things, but there's been quite a few. So I'd say somebody comes in with an acute pain, 9 out of 10, they've been told by either their primary ER or whatever, that's these other issues. And I'm able to see them and relatively quickly figure out, oh, it's not your shoulder, it's your neck. And, or vice versa. They were told it was this and it's something differently. And the patient was able to come out of there significantly improved and know that they've been bounced around, let's say, by different physicians in different places for months until we were able to actually see them. And I just happened to have seen this before. And I think that's a big one from being in the practice for a long time. You've seen so much.
Right.
Yeah.
So when someone comes to you and says, hey, I have this, and this, you can kind of go, oh, it sounds like this. Let's work that up.
Let's investigate that. Yeah.
So I think that's probably my bigger ones, is the ones that have been bounced for months. And then they come to me and I'm able to figure out exactly what it is because I've seen it before. And I'm able to get them on the right track quickly. And they're very appreciative.
That's incredible. A lot of great success stories that obviously exist, and the work that you're doing is phenomenal. Number of patients you think you see on average a day?
22. There's bad days.
There's real bad days.
It can get up to 27, 28, but most of the time I'd say anywhere between
Mhm.
18, 22. But that varies between news and house.
True.
News are a little bit more. So, you have 15 news
Yeah.
on there. It's going to be a rough day compared to
Right.
22 post-op. So I'd
So-
say 22.
Yeah.
Let's talk a little bit about the processing of a patient, because they may think I'm coming in to see Dr.
Uh-huh.
Patel today. That's not going to happen.
Sometimes it's not.
Most likely you're going to be their first stop,
Absolutely.
and you're going to be their last stop after surgery.
Absolutely.
Right. So and why do we do that? Explain, help the audience understand.
Well,
Mhm.
you've
Why
got
can't you-
physicians that need to be in surgery fixing patients. So they're
Mhm.
going to be in their surgery at least 2 to 2.5 days a week. So if you were to have them in clinic 4 days a week, they're not able to help you and fix you.
Right.
So we have to look at this transition of how things have changed in medicine in the last 15 years. So luckily, in my opinion, you're going to see someone that knows the situation and get you to the right person and get you fixed. Now, if it's ever outside my realm, and I'm not ever going to say there isn't, I have great resources.
Mhm.
There's always a physician in my office that I can bounce to and say, hey, this one's outside my realm. Now, it doesn't happen all the time, but I do have that opportunity, and then I can pull the doctor in, which I've done occasionally, and say, hey, could you take a look at this? So you're going to see the right person at the right time. Your first one is with me to get you in quicker.
Yeah.
So think of that, and most patients understand that. So I get all the ER slips every day, and I'll go through and say, this one needs to be seen based off of what I see on x-ray
Mhm.
tomorrow, next week,
Yep.
with physician, with me on a physician day.
Right.
So I try to get you the quickest care with the best person. But you're not going to be able to see the doctor
No.
the first visit most of the time,
Mhm.
because otherwise that could be a 3-week out,
Yeah.
and now you're mad about that.
Right. So even
Right.
post-surgical, though, you have an opportunity to follow up that patient and follow them
100%.
on their journey of healing,
So absolutely.
which is also critically important.
Yeah.
So
And if they say, hey, I really want to see the physician, I make sure they see that physician the second post-op, let's say,
yeah,
Mhm.
and make sure they're feeling comfortable that they're being handed off appropriately.
absolutely. Ken, you're doing a great job for us. We really appreciate it. And before we close today, Kirsten, are there any questions from our audience? None?
And before we fully close, I do want to mention to our audience that we are now, as of today, right now, streaming not only on Facebook, but we are also streaming live on LinkedIn and YouTube. So you can watch us on your favorite platform.
Oh, you.
If Facebook is not your favorite, you can watch us on either of those as well. So we are going to have the screen probably looks a little different. You might see some text pop up on the screen because we have a lot more capabilities now. So I just wanted to share that announcement.
Well, thank you. And Ken, thank you for your time today. Thank you for your contributions to our community, to our patients. You've been around a long time,
But
and we want you to be here a long period ahead of us,
I
because
appreciate it.
the work that you do, I get comment cards, and I'm not kidding you, every week, several times a month, just
Mhm.
talking about the great care that you give.
Great.
And it's pretty remarkable to see the lives that are transformed through your practice.
Great.
And I think you have one of the best teams that work
Absolutely.
together.
Mhm.
I mean, you guys click on all cylinders.
I have to put a point out there that the MAs
Yeah.
in our office help us
They're
keep
incredible.
it moving.
Yeah,
Mhm.
And without them doing great jobs for us, we wouldn't be able to do half the work we could. So
I
wanna
agree.
put that
Kudos
out
to
them.
the team out at
Yes.
Hillsdale Orthopedics.
Yes.
We appreciate each and every one of you. I'm sure you're watching today to see if Ken's going to flub up or if he even mentioned you, but he did mention you. So
Yeah.
you should be happy
I
about
made
that.
sure.
So thank you very much for your time, Ken, and your commitment to our hospital. And thank you, our listeners, for your contribution, for using our services like Ken in our orthopedics. It's because of your willingness to use our services that makes Hillsdale strong when you place Hillsdale first. And that's so important. In a time and an age which we're living today, where hospitals are closing and programs are divested, every day we're reading about a program here or a program there that's ended, and obstetrics at this hospital and home care at this department and hospital. And you see it all around us, even in Michigan, even in our region. And it's very disheartening. But what we know is that our strength comes from viewers like you, who not only listen to programs like this, but also come and use our services, because that's what drives our utilization and allows us to keep this operation moving forward. Today's times are very challenging for hospitals. And when people think, Rachel, bigger is better, how many times have we heard that?
Oh, all the time.
That's not the case, Rachel.
No, it's not.
Our quality scores many times are higher than our competitors. Our pricing is much lower than our competitors, and we can get things done very quickly. If Ken calls me today and says, "JJ, I think we need to change a process," I don't have to go through 27 committees.
Mhm.
I can say, "Ken, I agree with you. I think we need to look at this," and that's the beauty that we have of a local autonomy of our healthcare. And that only happens because you support us. So use our services. Bigger isn't better. Utilizing the services here that Ken said, this very rare for us to have the specially trained physicians that we have here and surgeons, but we bring those to you in our commitment to make sure that we build the full continuum of care so you don't have to leave Hillsdale. So we thank you, our listener. And if you're looking to join a winning team, Hillsdale Hospital's hiring right now. Go to our website, hillsdalehospital.com. Under the careers tab, you can find all those jobs listed. I think we have upwards of 25 or even 30 jobs. You don't have to have tons of degrees or experience or even be clinical. This could be a starting point for you in your career. Maybe you want to get in healthcare. You don't know how to do that. You can start by working right here in many of our entry-level positions. So check us out on our website. Also, opportunities like this exist. We're going to be interviewing individuals throughout the next few weeks about services like Ken's. And we also have an opportunity every week with our podcast to talk about the challenges of rural health. And we would love for you to subscribe wherever you get your podcast, Apple Podcast, wherever it is, to Rural Health Rising. Every Thursday, a new episode comes out. We record right here in the studio, Rachel, and we have some phenomenal guests that are from across this country. And we're really making waves and saying that rural healthcare needs to be saved in America. And we're leading that discussion right now. You'll hear later about conferences and summits that we're speaking at across the country to raise awareness for rural health. And then every Friday, WCSR 92.1, you have an opportunity to listen to a program that talks about what are we doing in Hillsdale County to improve the lives and the wellness of our community. So we ask that you check out those social media podcasts. Quotes. We look at opportunities for our staff to talk. There's a lot of quotes out there right now on Facebook about our capital campaign. I'd ask that if you're looking to give and you're starting your new tax year, consider Hillsdale Hospital. We have a capital campaign right now, and you can read those quotes on Facebook from our staff who are working every day in the trenches, who are talking about the services that we offer. And so check us out on Facebook. You also have an opportunity, I believe, to donate through our website.
Yes, hillsdalehospital.com/campaign is where you can find all the information about the campaign. And also you can donate there. There's also a link for capital campaign in the top main menu of the website. If you just go to the Hillsdale Hospital.
Make your donation today. We're raising $1 million in an attempt to try to help purchase some very needed equipment here at this hospital. We'd love to have your contribution. It is tax deductible because we are a non-for-profit, so you can fill that form out. We'll track it. We'll give you your receipt. And then we look forward to seeing you back here next Wednesday. And until then, stay safe, stay healthy, and stay Hillsdale strong. Thanks for joining us today.